Hello, my name's Denise Wilkinson. I'm one of the lead nurses for medicine at the Queen Elizabeth. This is my colleague Dr Beth White. She's a consultant in infectious diseases at Queen Elizabeth. Today we're just going to have a chat over some COVID questions and work through some slides. Over to you, Beth.
Thanks very much, Denise. Yeah, we're very aware that there's been an awful lot of discussion and there's increasing cases of COVID in our hospital, and we're really wanting just to provide a little bit of background information, a little bit of discussion about some of the infection control issues, and then a little bit about the treatment as well, just to try and support the nursing staff and make sure that we've answered some of the questions that we're getting on a day-to-day basis. I'm very aware that some of this is changing and that there's been changes fairly regularly, which is quite stressful for staff. And so the last slide that we have is actually just where to find the most up-to-date guidance, which is really important, so that you know where to access the most relevant information for you on a day-to-day basis.
And I would always encourage staff to ask questions and speak to their managers.
Yeah, absolutely. So, as I'm sure you're aware, at the end of 2019 there was an outbreak of an unknown severe respiratory illness in China, in Wuhan city. And they then discovered that this was caused by a novel coronavirus called SARS-CoV-2. And the disease that causes is coronavirus disease 2019, or COVID-2019, as we now call it.
So Beth, is this part of another virus as well? Just you mentioned SARS.
So it's a sort of sister illness to SARS. It is slightly different, and obviously it has been much more infectious as a virus. It has an incubation period of around 5 days typically. There's a range for that between 1 and 14 days. And it causes this kind of range of symptoms that you can see on the screen. So fever and a dry cough are very typical. Sometimes patients can have a productive cough. They often describe profound fatigue and pain in their muscles or tightness in their chest. Some patients describe a sore throat. Some patients have diarrhoea. And actually, quite typically, we're seeing patients describing this odd altered sense of taste or altered sense of smell with this virus.
You wouldn't expect all the patients to have all the symptoms though?
No, so different people will present with different clinical syndromes, but these are sort of the typical symptoms that we'll see a range of these in each patient. And some patients do present with breathlessness. The spectrum of illness is quite variable, but the vast majority of people will have mild disease. And I'm just showing this in the next slide here, where the majority of people will be in this sort of big yellow area. They'll have a self-limiting illness, a sort of flu-like illness that we've just described, that occurs for about 7 days. The vast majority of people will be getting better by that point, but in a smaller proportion of people, then they will develop a worsening hypoxia. They'll develop bilateral pneumonia typically at that point. And these are the patients that we're likely to see coming into hospital.
And I noticed at the bottom, Beth, that can happen relatively quickly.
Yeah, so when they develop an oxygen requirement, patients that are going to deteriorate can deteriorate pretty rapidly, as in over the course of a few hours. So that progression from a kind of hypoxic illness to then developing ARDS, which is this acute respiratory distress syndrome, can happen pretty rapidly.
And would that be an increase in shortness of breath potentially?
So increased breathlessness or increasing oxygen requirements in your patient. And if you see that on the ward, then it's really important to highlight that to the senior medics in your area. We want to involve critical care sooner rather than later if you've got concerns. So it's probably helpful to discuss the risk factors for severe disease.
Yep. Older
Older age is probably the most important one. So this graph that you can see on the right-hand side shows that about 75% of the deaths are in people over the age of 70. And in fact, more recent data suggests it's even more. About 86% of the deaths are in people over the age of 70 years old.
So does the data indicate the older you are, the increased chance if you catch COVID-19 of death?
Yeah, so older people are at higher risk of death than younger folk. But actually, it's important to remember that it's probably somewhere between 15 and 20% of people who are over the age of 70 or 80 who develop coronavirus, who will develop severe disease and have a risk of death. So actually, the majority of patients who are older still will recover from this. Comorbidities is also a really important area. So there's all of the studies show that things like hypertension or high blood pressure, diabetes, ischemic heart disease, and chronic respiratory disease all have a higher risk of severe disease. And cancer within the last 5 years is also another thing that's been flagged in the data.
And if you have more than one of these illnesses, Beth?
Yeah, so the risk increases as you accumulate comorbidities. So patients who have 3 comorbidities will have a higher risk than those who maybe just have 1 or have no comorbidities.
And you also mentioned cancer within the last 5 years, so if it's greater than 5 years, you're reduced risk?
Yeah, so we don't have data on that particularly. The studies are still quite vague about that. So I think it's probably to do with the immunosuppression associated with getting the treatments for cancer that is the risk. The other risk factor that we're noticing in older patients, so in patients over 50, men have a higher risk of severe disease than women.
Beth, we've talked a bit about the disease process. Will we go on and talk about the transmission of disease and what we can expect from that?
Yeah, absolutely. So the virus is thought to be spread by respiratory droplets. So this is either by direct contact, so a cough or a sneeze or close face-to-face contact within 2 metres, but it's also by indirect contact. So if I was to cough or sneeze and that was to go onto this surface, someone else was to touch it, then that would be a risk of transmission. Or if my hands are contaminated and then they touch a surface such as the keyboard and then someone else touches it and they put their hand to their eyes or their nose or their mouth, then that's where the risk of transmission sits.
And this is why we've got to be so careful about environment and our cleanliness in the environments that we work and live in.
Absolutely. So this is why the message about hand hygiene is so important. You need to be really careful to be washing your hands after touching things, particularly after taking off your PPE, but also before you eat. And just being careful about things like not having food in a clinical area is really important.
And you also mentioned about touching your face and touching your eyes. That's a natural reaction for many people.
I know, I'm very aware at the moment of how much I touch my face, and I think we just have to be really mindful if you're keeping your hands clean, and if you want to scratch your face, wash your hands before you do so.
And if you do go on and touch your mask or your PPE, again, just washing your hands.
Absolutely. So just being really careful to wash your hands after any contact with anything that has the potential to be contaminated.
I also noticed you've said that it can persist on surfaces for up to 72 hours.
Yeah, so there is data showing that it can sit on surfaces for a prolonged period, but it is worth remembering that that's most likely to be infectious right at the start. So when a surface is wet or it's just been contaminated, that is the higher risk, and the risk does reduce over time.
And it says that infectious period is typically 7 days. Does that mean the patient's still infective after 7 days?
Yeah, so for people with mild or moderate disease, then they are likely to be infectious for 7 days, and we know that infectivity drops off really dramatic after that. I suppose a caveat would be patients who are unwell. So the patients with severe disease that we might have on our wards, or those patients who are immunocompromised, then you may well see that infectivity carrying on longer.
So would we be rescreening after a certain period of time for these patients?
Yeah, so if you have a patient who's still in hospital after 7 days, you would want to rescreen them with a swab. You wouldn't want to do that before 7 days because it'll certainly still be positive. But after that, if you swab and they're negative, you'd want to get a repeat swab to ensure that's an accurate result after 24 hours. If the result is still positive at that point, then what we advise is to wait 3 days and then re-swab again at that point. So high-risk surfaces, this is just a simple reminder to be careful about the things that you maybe share with other people. So careful when you're touching door handles or touching the keyboard or a mouse, using phones on the ward. These are things that you want to keep clean and wash your hands
So the
after.
recommendation would be cleaning regularly, these the common things that we use within the ward?
Absolutely. So yeah, being really careful to keep these things clean in particular would be very important. We should go on and talk about personal protective equipment.
There's been lots of changes over the past couple of weeks in PPE, Beth.
Yeah, so very aware that the guidance changed on the 2nd of April, and I think that's hopefully helpful and clarifies things for folk. The full guidance for this can be found on the HPS website, so I think that's a really important place to start if you want to just clarify what you need to do. But the local infection prevention control manual that you'll find on your desktop, that is also a really helpful resource, and it has this useful GGC video. That's the YouTube link that I've got at the bottom there. which shows you how to put on and take off your PPE correctly. And it's really important, particularly when you're taking off your PPE, to remember not to touch the surface, the front of your PPE. So that's either the front of your mask. You need to really remember to take that off from the back of your head. Same with the visors. And when you're taking off the gown, you want to be pulling it off from the back rather than touching the front of the gown or the apron.
And I'm presuming that's due to the contamination at the front of it because you're front facing the patient.
Spot on. So that's the area that's most likely contaminated. Similarly with gloves, you're taking it off from your wrists rather than touching the fingers on the gloves. And it's really important if you've got a mask on not to fiddle with the front of it. So you don't want to be touching the front of that at all if you can help it.
I think that's the difficult bit, isn't it? Because it's just natural to touch it. But
Absolutely.
if you do touch it by accident, washing your hands.
Yeah, so it's really important just to wash your hands after that. So this is a kind of a pictorial representation of what we should be wearing on the ward in wards that have suspected or confirmed cases of coronavirus on them. So the left-hand side of the picture shows you what we'll be wearing on the vast majority of wards, because we're not likely to be doing aerosol generating procedures there, and we'll talk about that in a wee minute. But the PPE that we should be wearing is a full face shield or goggles, a fluid-resistant surgical mask, a simple apron, and this pair of disposable gloves. And when you finish seeing the patient, it's really important after every patient that you take off the apron and the gloves and you wash your hands. But you can keep the visor and the mask on for the duration of time that you're in doing sort of a set of jobs on the ward, so you can keep them on for several patients.
And I think if people have got questions around that, they should speak to their senior charge nurse or their managers or infection control.
Absolutely. Yeah, it's really important just to be sure about what you're meant to be doing in your ward, and if you're not sure, it's really important to ask. In areas where there are no cases of suspected or confirmed COVID, then the PPE is as per your normal infection control guidance, but it's important that you do make an individual risk assessment for every single patient. So if you've got concerns about a patient, if they're coughing or whatever, then you still can wear the fluid-resistant surgical mask and visor if you've got any concerns.
And these guidelines, Beth, are coming from a four-nation approach and they're changing frequently, so I presume Health Protection Scotland's the best place to get up-to-date information?
Absolutely. So if you're not sure what you're meant to be doing on the ward, speak to your senior charge nurse and or look at the Health Protection Scotland guidance, and hopefully it'll provide some clarity for that. This table is really busy and I don't really want to talk to it particularly, but it actually is a very helpful table telling you exactly what you need to do in certain scenarios and in different ward settings. That's from the Health Protection Scotland guidance, so I'd really advise that nurses go and have a look at that and sort of read that carefully to understand what they need to do in their own clinical area.
It's a really helpful website if you can have a look at it.
Yeah. But this is hopefully just a slightly more simple representation of what we're supposed to do if you've got COVID patients on your ward. So if you're within 2 metres of a patient, it's really important that you're wearing disposable gloves, a disposable apron, fluid-resistant surgical mask and eye protection. And that's either goggles or a visor.
And that's because of the close contact that you're having with the patient.
Spot on, because we think this is droplet spread. If you're more than 2 metres from a patient, then you should still be wearing the face mask, but you just need to risk assess whether you need to wear eye protection. And the need for eye protection is really if you're concerned about any splashes to your eyes, that kind of mucous membrane contamination.
Yeah.
So aerosol generating procedures is a question that I'm often asked about.
The staff in the ward ask lots of questions about it. Can we just talk through what is an aerosol generating procedure and where we would expect these to be happening within the hospital environment?
Absolutely. So aerosol generating procedures are procedures that will cause very small particles of virus to sit in the atmosphere for a more prolonged period. So droplets typically will be coughed out and then will come down onto the floor quickly and immediately, but aerosols can sit in the atmosphere for a more prolonged period. Procedures that can cause that would be things like non-invasive ventilation, CPAP, and high-flow nasal oxygen. These would be the typical things that maybe people would think about using on the ward.
And high-flow nasal oxygen, Beth, is not just the Hudson masks that we use on the wards, it's a specific type of machine?
Absolutely. So there's a machine that would provide kind of a bit of positive pressure to the lungs with a specialised nasal cannula. So yeah, it's a very specific form of treatment.
And it's not something we would routinely see in a ward setting?
No, this will be something that's been done in critical care. So aerosol generating procedures should almost exclusively be done in critical care at the moment. It's really important to remember that nebulizers are not aerosol generating procedures.
So that there's lots of anxiety about aerosol generated procedures and nebulizers not being included in that, Beth.
Yeah.
Is there a specific reason why they're not included?
Yeah, so I'm going to read the guidance from HPS because I think it's actually a really helpful way of putting this. So they say that during nebulization, the aerosol derives from a non-patient source, i.e. the fluid in the nebulizer chamber, and it doesn't carry patient-derived viral particles. So if a particle in the aerosol coalesces with a contaminated mucous membrane, it ceases to be airborne and therefore will not be part of the aerosol.
So they're safe to go in the ward?
So you can do that with a fluid-resistant surgical mask on, absolutely fine.
I also note you've put chest compressions and defibrillation as part of as an aerosol generated procedure. Can we just talk through that?
Yeah, so there have been changes to the guidance, I'm sure everyone's aware of that, but chest compressions are not aerosol generating procedures. So if you're a first responder to arrest, you can put on the fluid resistant surgical mask, the standard PPE, and begin chest compressions. And then when the arrest team arrives, you can leave the room and put on an FFP3 mask if you're fit tested for that, in order to go in and support the rest of the arrest team. And
the change in mask, Beth, I presume it's to do with the aerosol generated procedure because we're potentially doing airway support at that point?
Absolutely. So airway support is something that we are concerned about in terms of aerosol generating procedure. So when the full arrest is going on, then FFP3 masks should be worn. So I want to talk briefly about the management of COVID. So I want to just talk about treatment, and the mainstay of treatment is oxygen. And as oxygen requirements rise, then patients may require mechanical ventilation. Now, when patients go onto a ventilator, the mortality is actually very high. So it's really important that we choose the correct patients for that. And that's why every patient that comes into hospital with suspected or confirmed COVID has one of these forms filled out that you can see here.
And is it medical staff that are filling these forms out, Beth?
Yes, so the consultants down in ARU5 and in all the pods down on the ground floor will fill this out for every patient. And there are 4 different groups that a patient can be put into, 4 different categories. So red would be patients who are definitely for escalation. Orange is where there's a bit of uncertainty about that, it's not clear cut. And those patients are all discussed at an MDT at 1 o'clock every day. And that's a discussion between a critical care consultant, respiratory and infectious diseases. If those discussions are not then written onto the form, then the nurses will be able to find that on portal. It's uploaded onto the portal site. For patients who are not for escalation, then they go into the blue category for ward level care. But remember, this is still active treatment with oxygen, and only a proportion of them will require palliation. And then green is for patients who are felt to be at low risk of deterioration.
So can I just clarify the blue level, Beth? So that's for ward level care, but not for escalation, but for treatment in the ward?
Absolutely. So it's still active treatment. However, you would still anticipate that these patients would have a DNA CPR forming for the vast majority of them, because if they do become less well, then you don't want CPR to be performed on them. That just wouldn't be appropriate.
And is that a discussion we should be having with all potential COVID patients?
Yeah, so for patients who are not for escalation, then DNA CPR forms should be considered and should be put in for all patients where it's not appropriate. In terms of treatment, we've discussed that oxygen is the mainstay of treatment, and we need to be aiming for oxygen saturations of 90 to 94%. So we're stipulating that quite carefully in the guidelines, with a slightly lower rate of 88 to 92% in patients who are at risk of type 2 respiratory failure. So COPD patients and such like.
And those oxygen levels of 90 to 94% are slightly lower than normal that we would expect in the ward?
Yeah, so the levels are lower so that we are able to see more clearly when patients deteriorate. So if patients are aiming with a 90-94% rate, then it's much easier to see when their respiratory rate rises or their oxygen requirements increase.
And I've noticed you've used Venturi masks. Is that a more accurate way of assessing?
Yeah, so the Venturi is able to provide a controlled amount of oxygen for the patient, and it means you know exactly how much oxygen they're getting. So do use Venturi masks in order to provide oxygen for these patients, and it should be prescribed on their Cardex what they should be getting.
And is that a good indication of a patient's requirement and dependency level if their requirement goes up for the Venturi masks?
Yeah, so if patients start to rise in their oxygen requirements or their Venturi mask goes up, then you do want to discuss them with critical care if they're for escalation. So patients who are needing 40% oxygen, then the doctors probably will be discussing them with critical care if they're for escalation.
And if they're not for escalation?
Yeah, that's also really important. So as we said earlier, that deterioration can happen really quickly. So if patients become very breathless and they're not for escalation, then it's really important to put palliative and anticipatory care medication measures in place sooner rather than later. There's evidence, or there's increasing knowledge, that actually oxygen doesn't really help with that air hunger, and opiates are probably a much better treatment for that.
Is it worthwhile getting palliative care involved at an early staging?
Spot on. So palliative care are really keen to be involved with these patients. They have a lot of experience. There's some really good guidelines out there from palliative care, and I know that they're very happy to be involved if we've got any questions. The other thing that's important if a patient is for palliation is we are allowed to have one member of their family come and sit with them at that time if you think that they are deteriorating. So it's worth considering having that conversation sooner rather than later if they start to deteriorate. So IV fluids is the other aspect of treatment that I'd quite like to discuss. It's really important that we get a balance here when we're thinking about fluids. We know that too much fluids and too fast can exacerbate the acute respiratory distress syndrome. So we don't want to be pushing too much fluids for these patients, but equally patients who have a high fever for a sustained period can often have very high insensible losses. So you don't want to run them too dry, but you don't want to run them too wet, and it's really important to try and get a balance with that.
So it's really important to keep accurate fluid balance charts for these patients?
It would be helpful remembering that the insensible losses will not be calculated on that. So sometimes patients might require a little bit of additional fluid if they're struggling with their oral intake, but trying not to push that too fast.
So it's important to get IV fluids prescribed in advance?
Yeah, so having the doctors think about that is really helpful. The other point that we thought would be really helpful to discuss is how to take the nasopharyngeal swabs. The nasopharyngeal swab result is only as helpful as the swabbing that has been done, so if the swab isn't done correctly, then you can't trust the result. So when you're taking a swab, you want to be swabbing around the back of the throat, not touching the cheeks or the tongue or the teeth. And when you're doing the nasal or the nasopharyngeal swab, you want to be going right to the back of the nasopharyngeal cavity, so along the base of the nose, not up into the nostril. And it's really pretty uncomfortable for the patient. So if you've done it and it has been uncomfortable, it probably means you've done it properly.
And there's a video online, I believe, that you can view the swabbing technique?
Absolutely. So if you want to check that out, I think that can be got through the IPC manual on desktop. And this is just a final slide just to say where we're going to find these guidelines. So the main guidelines will all be on the Health Protection Scotland website. And this is a really helpful resource.
So they feed into the Four Nations approach, Health Protection Scotland, don't we?
Absolutely. And our local guidance for the infection control guidance will come through the IPC manual that you can get to your desktop, and it has some really helpful resources there for staff. In terms of clinical guidelines, there is a COVID-19 section to the clinical guidelines directory that you can get on StaffNet. And it has some helpful information on discharging patients and some of the stuff to do with difficult conversations that we have to have at the moment.
There's also a lot of information about frequently asked questions for staff and staff resilience web pages to follow as well, because it's always a very distressing time for everybody.
Yeah, I think this is very stressful. We have to recognise that for staff, so it's a really helpful resource for staff to access.
Great. Well, thank you for your time, Beth. I think this was very informative and I appreciate sitting down with you to discuss this.
That's an absolute pleasure, Denise. Thanks very much.
Thank you.